Good day to you, class. My apologies for not having this done already, but there's been a lot going on, and quite frankly, I just haven't wanted to do it. So I didn't. I know that's not a good excuse, but it certainly is an excuse. Anyway, this is Chapter 34, Pediatric Emergencies. This was definitely a class I intended on having my children come and poking and prodding them with sticks and stuffs. It would have been fun, and hopefully some point we still can. And I don't know, what else could I say? This all stinks, and we got to do the best we can. So, Chapter 34, Pediatric Emergencies. Competencies. 7, 8, 9, and intro. So children are different. Giant heads, I like to think of them as bowling balls on a broomstick. Giant heads on a little tiny body. We know they differ a great deal. They're not as developed. Sometimes they're a lot more direct and honest. Other times they're very subdued and introverted. Stranger danger. And their anatomy, their physiology is all different. Things work at different speeds. And it's important that we are aware of that. A lot of this is going to stress the different actions for different age groups, and they are important. Remembering to get down so you're eye to eye, eye level with them, and talk to them, not just their parents, will go a long way. We need to be aware that ultimately every pediatric patient has two patients involved, the patient and the caregiver. If we could calm mom or dad down, we can most likely keep the child calm as well. And that's important. And we need to sometimes focus on that before we could really start assessing the child. Then we have our age groups and emotional changes. Our age groups are infant is the first year of life, toddlers 1 to 3, preschool 3 to 6, school-age children 6 to 12, adolescents 12 to 18. These numbers are slightly important when it comes testing time. They're basic guidelines behind your thought processes for actual patient care. Oop, wrong button. Let's try that again. Boom. Infant is the first year of life. Neonate is the first month of life. So 0 to 2 months, sleeping and pooping and eating. That's what they do. First month after birth is neonate or newborn. They respond to physical stimuli. They say they cannot tell the difference between parents and strangers, but I don't believe it. Having 3 of my own, I think from a very young age they have a clue of who they belong to. And crying, we need to know different types of crying, and specifically their caregivers. Is that a painful cry? Is that a hungry cry? Is that a gas cry? These are things that the mom will tend to know. Sometimes the dad, but at least early on, that the early first few months, mom definitely knows. Basic needs: food, warmth, comfort, and a clean diaper. They could hear, you need to be calm, you need to be quiet. Head control is limited, meaning they have none. It's up to you to control that head. You need to keep them warm. They will not stay warm on their own. That's rather important. The unbundle situation, if you want to assess somebody, especially, even if it's warm out, we still need to keep these kids swaddled. We might need to unswaddle to do an assessment, and then it's really important that we get them wrapped back up as soon as possible. 2 to 6 month old infant, they're going to be a lot more active. They're going to be a lot more aware. They're still very difficult to assess. They can't tell you anything. But they should focus on you. They may follow objects with eyes. They should respond to your stimulus. And when they're not, when they're just very subdued or, vacant stares, that's when we know there's a problem. 2 to 6 months, they're starting to really pay attention to what's going on around them. Both hands and their mouth to examine everything. This is when kids start to sleep through the night, which is heavenly for the parents. Rolling over, crying, they could be irritable due to all kinds of things. Stomach concerns are the most common. Lack of eye contact can be an indicator of serious illness. Depressed mental status, delay, or a delay in development. That's more of a long-term thing, isn't it? But the lack of eye contact is important. Babies, if you speak or touch, it should focus on you. And if it doesn't, it's probably the sign of a problem. 6 to 12 months, this is when dangerous activity begins to come into play. Begin to crawl and finally walk is important. The kids that are crawling around, there's no telling what they could get into. They could find the loose pill on the floor that somebody dropped 3 months ago and couldn't find, or dropped and didn't even know it. So there might not be any clue with the caregivers that what's going on is a medication overdose. So we need to always think about those things when we're dealing with these little kids. And then physical injury from falling down and going boom becomes a concern. Luckily, itty bitty babies are rather pliable. They're bouncy. They're rubbery. So even a fairly significant fall tends not to hurt them too badly. The issue we come into is that we really can't tell, because it's hard to assess these kids. They can't tell you their head hurts. All they could do is scream, which makes it hurt more. 6 to 12 months, teething begins. I don't believe that this starts, I think putting things in their mouth starts a little sooner, but here you go, textbook definition. This is when they're going to start choking and poisoning concerns, is 6 to 12 months. Separation anxiety begins now, probably began sooner than this. Assess your patient with the caregiver in sight or with the patient actually in the caregiver's arms. Persistent crying or irritability can be symptoms of serious illness or a symptom of being a girl. Assessment. Observe them from a distance. Once you get closer, they tend to react to you, and generally not happily. I mean, most of us are big and scary. Caregivers should hold the baby as much as possible. Make sure your hands are warm. Try to warm up the end of your stethoscope. And save anything that might be at all painful for the very end. Gain their trust and then ruin it afterward. After infancy to 3 years of age is a toddler. Rapid changes in growth, development, talking. 12 to 18 months, they're walking and exploring, learning to open doors, drawers, climbing into boxes, all that fun stuff. For the most part, these kids aren't afraid of anything. They really haven't experienced pain yet. So we all know our toddlers do all kinds of crazy things. They're going to start imitating their older children and parents. So your second-born, third-born is trying to be just like their bigger siblings. And that could cause a lot of issues because they're really not big enough to do what older bro or sis is doing. No major body parts? Huh? Anyway, speak 4 to 6 words at a time. Very difficult to understand. We often say that Sarah and I speak Harper and not too many other people do. Not be able to fully chew food, not be able to pay attention long enough to fully chew their food. (18 to 24 months, still a toddler. The mind's rapidly developing, the vocabulary is increasing every day, able to name things, begin to understand cause and effect. This is when they begin to understand that if they jump off that bed, it's probably going to hurt. Balance and their ability to walk is getting better. Their running skills might take longer to get good, which is why kids that run fall down so much. Their climbing skills are going to improve rapidly, and they're going to want to climb. And then the stranger danger comes in. They'll cling to their parents, to their favorite stuffed animal. I mean, my son's 10, and if somebody touches his wolfie, he loses his mind. So that's all too real to me. Any comforting objects when available. For sure, if they could bring along their favorite stuffed animal, I would encourage it. You should too. Stranger anxiety. These kids generally don't want us to touch them. My kids are an exception to that rule. They will run up to anybody and give them hugs. They'll have a hard time describing pain, which is true. The first time Colt had croup, it wasn't really pain, but it was difficulty breathing, and all he could tell us is he had a cough in his throat. Phoebe was sick as well, like really sick, so we were more concerned about her. Kept telling Colt to just, whatever, kid, yeah, you got a cough, we don't care. And then at like 12:30 the next morning, he woke up with a barking stridorous cough and had an airway of about 3 millimeters. So yeah, you need to pay attention to what they say and try to translate it into actual human speak. Begin 1, 2, 3, 4, 5. 5 dashes down. Begin your assessment at the feet. This is very important with kids. Do not go directly in and start poking and prodding their melon ball head. We want to start at the feet and work our way up. Persistent crying again. Symptom of something wrong. Previous medical experiences may lead to hesitation toward you. The only thing they might know of a doctor or an ambulance crew is that time their doctor gave them their last immunizations, and it hurt. So they might be wary of what we're going to do. It might be hard to gain trust. 3 to 6, simple language effectively. They could really communicate. Walk and run, throwing, catching, kicking during play and during anger. Toilet training is mastered, hopefully. Imagination can be fearful about pain. May believe injury is a result of earlier bad behavior. Not so much. Learn which behaviors are appropriate and inappropriate, and then do what is inappropriate because it's generally more fun. Foreign body aspiration, airway obstruction is still a high risk. So this is going to go on for quite some time. We need to be concerned about the fact that their airway, their throats are like funnels. The mouth, the oral cavity is big enough for their whole fist, and then their airway is about the size of a drinking straw. Excuse me. Assessment can understand directions and be specific in describing painful areas. So you could ask them direct questions and they could give you direct answers. And most likely, if something's wrong, they do want help and they will answer your questions. Again, most of what you're going to learn is from the caregivers. Use simple words and be direct with them. Look them in the eye, be at their height. Don't lie to them. Don't lie to any patient, not just a child patient. And you might be able to distract them while you're trying to do your thing. So begin your assessment at the feet and move to the head. Cover any wounds or cuts or scrapes. You know how much kids love band-aids. And protect their modesty. Keep them covered up. So 6 to 12, they think they're adults. Everything's black and white, can think in concrete terms. Everything's black and white. They can respond to your questions and can help take care of themselves. This is the stage at which they should be doing things for themselves. School is important. To who? A lot of times your younger kids up to 2nd or 3rd grade, they really like school. They want to be at school, which is a wonderful thing. And especially my kids, who are surrounded by me, really have a firm grasp on what death is. They could be fearful that they're injured and that they might die, and that can make it even more difficult to treat them. Assessment could be more like adults at this point. Gain their trust, talk to them, not just to the caregiver, but talk to your patient. At this point, school age, we could start at the head and move to the feet. If it seems like it would still be in your best interest to gain their trust by starting at the feet, then go ahead and still do it. It's okay. Give the child choices. Ask only the type of questions that let you control the answer. So think about that for a minute. Don't ask wide open-ended questions. Try to keep it, yeses, nos. Give options for what their answers could be. Don't bargain or debate. You got to use your mommy voice sometimes and be an authority figure, but also be kind and compassionate and make them know you're their friend. Let them play with the stethoscope. Let them play with the blood pressure cuff. Simple explanations about what's causing their pain, what you can do about it. If something you're going to do to help their pain is going to hurt more at first, like splinting the arm where it's going to hurt more at first, you need to explain that to them. And, get parents and caregivers to help you, especially to distract them while you're doing this. Now we get into our adolescents, able to think abstractly and can participate in decision making. Again, they are your patients, and you need to treat them as competent humans until proved otherwise. They should be able to discriminate between right and wrong, and then again, they're probably going to go with the wrong choice. And hopefully they're starting to incorporate values, but that's up to their mom and dad to instill, or whoever their caregivers are. They're now becoming more physically similar to adults. They're going to shift to friends for support more than family. Romance becomes a thing. Puberty, body image, appearance, privacy, these things start to matter at, 12 years or so. Risk-taking, indestructible. That's so true, especially with teenage boys. They want independence. All that other stuff matters. Mood swings and depression. They're talking about females there. They can understand complex concepts, treatment options. You need to involve them in the decision-making process. Provide choices and lend guidance. EMT of same gender should do physical exam if possible. Sure, absolutely. But then again, remember, we are all professionals. We are all professional healthcare providers. And sometimes men have to treat females and vice versa. And you cannot act uncomfortable. You have to be a professional and just get your job done. Allow them to speak. Give them time to respond to your questioning. Do them and you a favor and try to do most of your questioning in the privacy of the back of the ambulance. A lot of these kids don't want to share what's going on with mom and dad, so we need to be aware of that and give them the opportunity to share with us somewhere where mom and dad are not going to hear them. And we all are aware that teenagers are risk takers and that a lot of what they're doing is going to cause themselves harm, which is why we're going to end up showing up. Female patients may be pregnant. Assume they're pregnant until proven otherwise. Ask them questions about it away from the caregivers. And talking with them can distract them from what's going on. Physiology, the body's growing, changing, hormones are racing. Airway is a big one. The anatomy of the airway is just different. It's smaller, it's shorter, Lungs are smaller. Heart is way up top in their chest. The glottic opening is higher and like sort of back more. And neck appears to be non-existent. So true. So many kids don't seem to have a neck at all. So the airway, larger, rounder occiput, so that's the base of the skull. Proportionally larger tongue, I mean it's giant. U-shaped epiglottis, it's long, it's floppy, it's hard to control. That's why they choke when they drink more often. Rings of cartilage aren't as strong in the trachea, and a funnel-shaped upper airway. And there it is. The trachea is about the size of a drinking straw. Airway is easily obstructed by pretty much anything. Infants are nose breathers. Suctioning of infants' nose will help them breathe and generally calm them down. 20 to 60 breaths is normal for a newborn. When you stimulate that newborn, the breathing rate should go up exponentially. They need twice as much oxygen, which is why they breathe twice as much. Risk of hypoxia is greater in an infant. Muscles of diaphragm, I mean, their diaphragm pretty much controls all of their breathing. Pressure on the abdomen could cause respiratory compromise. If they have some sort of crush injury that's stopping the diaphragm from doing its thing, you're going to have respiratory compromise. Yeah, spinal immobilization device, you want to be careful strapping them down to anything. Enough pressure to keep them there. Never too much pressure to actually restrict. Gastric distension, constipated, could affect their breathing. Breath sounds are easily heard because they're so thin. Detection of poor air movement or complete absence of breath sounds might be more difficult. I don't know why. Ultimately, because their deep breaths aren't all that deep to begin with. You know, they sound to us through our stethoscopes to be shallow breathing, even when they're breathing perfectly fine. So this is important. You need to know pulse rates for the age groups. It's like extremely important for testing purposes, for patient treating purposes. Infants, around 160 beats per minute. Very hard to count by palpation. They will compensate by constricting vessels in the skin, shunting, right? We've talked about that, which causes diminished blood flow to the extremities. Their heart rate will go up to compensate further. Pallor, which is a pale appearance, weak distal pulses in the extremities, delayed cap refill, and cool hands and feet are the best way to tell that their body is shunting. So here's a very nice chart for your heart rates, and we should spend some time looking at this and trying to memorize it to the best of our mental abilities. Because again, this stuff can come back. You can see this stuff in testing, and it can help you treat a patient in the field if you know what's considered normal. If you look, they're pretty big ranges for normal, right? Nervous system is underdeveloped. It's going to take a while. Head to body ratio is larger, meaning the head is larger. Occipital region of the head is larger. Subarachnoid space is smaller. So the brain doesn't have as much cushioning around it as the adult does. Brain tissue and cerebral vasculature are fragile. So we need to be aware of that. Traumatic injuries could shear their spinal column, could shear their cervical blood vessels. All big concerns. Higher cerebral blood flow, oxygen, and glucose. Yeah, the child's brain needs a lot of fuel all the time. Any hypoxia or low blood pressure could cause severe brain damage, and we need to try to protect against it by treating for shock. Keep them supine, keep them warm, give them oxygen, do what you can to support. Spinal cord injuries are less common because everything's so bendy and rubbery. Suspected neck injury, perform manual inline stabilization or follow local protocols. Manual inline stabilization is pretty much local protocols. We can use collars on these kids, but we need to make sure that it's a pediatric size collar and that it fits appropriately. Less protected from trauma. What's up, partner? The organs are basically larger, more anterior and close to one another. So when we look at the adult quadrants, things are spaced out. Your organs are pretty much in their quadrant, and it's pretty simple to remember. But the kids, they're all sort of squished in there, and they might be overlapping where they are. So in the end, if you get a swift kick to the stomach, the chance of hurting more than one organ is real. Open growth plates. Bones are softer, more flexible, more prone to stress fractures. Generally, you're going to get the green stick type fractures where they splinter as opposed to just a clean break. And then bone length discrepancies. If this kid damages its growth plates, there's a good chance that its limbs or legs will grow at different rates. We need to make sure that we splint every extremity injury. Infant head soft, flexible. The fontanelles are the parts where the bones haven't fused together yet. Particular stages of development is when they will fuse together. Ribs and vital organs are less protected. Yeah, because the ribs aren't as strong. Thinner skin, less subcutaneous fat, so there's less insulation, there's less of a protective layer. Skin, you get a lot deeper burns with these kids than you would in an adult. Body surface area to body mass ratio. Fluid and heat loss is more of a concern. Higher ratio of body surface area to body mass leads to larger fluid and heat loss. So, specifically in the burn situation, but really any situation, just being exposed to cold conditions, your environmental emergencies. Assessment begins at time of dispatch, just like for any patient. You need to prepare mentally for treating the child. That's a true statement. Pediatric size equipment, age appropriate physical assessment, your toe to head situation. We also want to consider, does our boo-boo bus have a pediatric kit that has all the pediatric size stuff in it in one location? If it is, you want to make sure you grab that when you go in to tend to this patient. Age, gender of child, location of scene, chief complaint, mechanism or nature, and you're going to hopefully get all that from your dispatchers. Hopefully. Ensure precautions, ensure standard precautions, ensure special precautions. Note how the patient is found. Look for safety threats. I like the bottom one, especially now it's poignant. May be a safety threat if he or she has infectious disease. We need to try to be aware of this and go in with proper PPE. Environmental assessment. Look around, see what's going on. What's the situation you find this patient in? Get as much info as you can from parents and caregivers. They're probably going to have much better clue what's going on than your patient is. And don't discount anything your patient says either. So you want to listen to all involved, the caregivers and the patient. Documentation, dangerous scene conditions, and inappropriate statements from caregivers. So remember, we're mandated reporters, and if it seems like something's not right, the caregivers or parents are acting a little hinky, we need to have a high index of suspicion that they're doing something not right. Traumatic scene. Assume the injury was significant enough to cause head or neck injuries. If the kid's unresponsive or unable to communicate just due to age, we need to have a high index of suspicion of severe injuries. Cervical spine immobilization as best we can, manual if necessary, pedi collar if it'll fit appropriately. We need to make sure it fits appropriately. If we put on a pedi collar and it's in a bad position, or it's not properly secured, or it's too long or too short, you're going to hurt the kid more than you're going to help them. It's really important. Neutral position of the airways, that slightly sniffing position we discussed months ago in CPR training. Not all the way back, not forward. Remember that airway is like a garden hose. If they're too far forward, it's going to kink. If it's too far back, it's going to kink. We want to try to keep it in line and even. The triangle, pediatric assessment triangle. This has been around for a long time. I mean, here the picture says Academy of Pediatrics, circa 2000. So it's definitely a thing, and all these things together are going to help you get the full patient picture. So it is interesting. It's not something you're going to need for testing, I don't believe. But it is something you should be aware of. And it's a purely visual inspection. You could check all this out from 5 or 6 feet away just looking at the child. And quite frankly, for pediatric assessments, we're going to get most of our information just by looking at them, how they're acting, how they're breathing, what their color is. All that's going to have a great effect on what kind of care we're going to give them. So appearance, how conscious are they? Are they interacting with you? What's their muscle tone seem like? Are they flaccid, just sort of floppy? Or are they holding their limbs and their head appropriately for their age? Use your AVPU scale and modify as necessary for the pediatrics age. Is it a normal level of consciousness? Do they act appropriately for their age? Do they exhibit good muscle tone? And can they maintain good eye contact? Eye contact is very important in these assessments. Tickles, mnemonic helps determine if patient is sick or not sick. Tone, interactiveness, consolability, look or gaze, speech or cry. I'm not too concerned about you memorizing tickles. Work of breathing. The body will attempt to compensate for any abnormalities in oxygenation and ventilation. They'll try to breathe faster. They'll use accessory muscles. You'll see retractions where the muscles in their neck and shoulder get sort of sucked in when they try to breathe in. Their nose holes will flare out, nasal flaring. They'll breathe really fast, and they might be in the tripod position. These are all signs that they're having difficulty breathing. Head bobbing is another one. That's generally a severe difficulty breathing where they're now not strong enough to hold their head up. That's a problem. Damn it, I was paused that whole time. Where was I? So the body will try to compensate for abnormalities in their breathing. And they'll try to compensate more and more with, trying to breathe harder. It'll manifest with abnormal airway noise. So this is noise you're probably going to hear from across the room, not necessarily with your stethoscope. Stridorous coughs and barks, you're going to hear that. The croup cough, you don't need a stethoscope for that. Asthma, wheezing, and a pediatric, you're going to hear that whistling from far, far away. Accessory muscle use, they're using all their chest muscles to try to expand everything to breathe in. Retractions, where the muscles appear to get sucked in whenever they try to breathe in. Nasal flaring, those nose holes get bigger and rounder. Tachypnea, they're just breathing really fast. And they're tripoding, they're sitting in that tripod position. When the cardiac output fails, the body shunts blood from areas of lesser need to areas of greater need. So it's going to shunt the extremities for the core. Pallor of skin, mucous membranes, cyanosis in the mucous membranes might be noticed. Mottling, which is just like a speckly skin appearance, is a sign of poor perfusion. And again, cyanosis reflects decreased level of oxygen. Cyanosis, we're going to see pediatrics, you might actually see it in the fingertips. You'll see it in the lips. From PAT findings, you will decide if the patient is stable or requires urgent care. So this is all from your little triangle. You're going to tell right away that this kid is really sucking wind or that they're pretty much okay, and it's a first child and mom and dad are just totally overreacting. External hemorrhage, you got to work fast. Circulation, airway, breathing, CAB. Tourniquets, you might want to go right to tourniquets. The issue with our most common cat tourniquet is that for very small children, it won't get tight enough. Luckily on our side is pressure. And with a lot of these kids, even with very severe arterial bleeding, we can control it with direct pressure because ultimately they don't have much blood pressure on their best day, and it's easy for you to fight against it just with direct pressure. So we should try it first. If it looks like we can't, try the tourniquet. But for a small child, I mean, you all met Phoebe, she's 7, and the tourniquet pretty much will work on her, but she's getting to be kind of beefy, verging on fat. So she's got some mass to her arms and certainly her legs. But, anybody smaller than her, there's a good chance that tourniquet's not going to work. Pediatric patients, you will now perform a hands-on airway, breathing, and circulation assessment. Assess and treat life threats as you find them. Airway first, breathing second, circulation, disability, and exposure. Which disability? Specifically, they're disabled due to injury. So they're not able to move their arm because it's broken, that kind of thing. And exposure is exactly that. Exposure to extreme heat, cold, water. Airway, if it's open, and will remain open, assess respiratory adequacy. So if they have a patent airway, then move on to see how they're breathing. That's what they're getting at there. Unresponsive or difficulty opening the airway, ensure it is positioned correctly and clear of stuff. Foreign bodies is a big one, and it could be the marble, the Lego piece, a big hairball that they found and figured they'd chew on it. There's no telling. Head tilt, chin lift, or jaw thrust according to mechanism of injury. If you fear a neck injury, don't do the head tilt. And remember, we don't need to hyperextend like we do for an adult. We want it pretty much in line. Neutral sniffing position. So the sniffing position, you just raise your nose up a tiny bit to smell something. We all do it, and you don't even know you do it. Next time you're around a small kid, ask them to smell something and see how their head tips back just a little bit. Establish whether they could control their own airway or not. So it just said I was paused again. I'm very confused. Oops, and I just passed a slide and can't go back. So hopefully you had a chance to look at that one, or you could go back to it. I have no idea what it said, so moving on. Circulation, does the patient have a pulse? Are they bleeding? Are they in shock? Palpate brachial or femoral pulses. I could tell you that brachial, the upper arm, the inside of the upper arm is very easy to assess. I don't know that I've ever tried to get a femoral pulse. Older than 1 year, palpate the carotid. Strong central pulses usually indicate that the child is not hypotensive, just like an adult. Now, if they have a good strong pulse, they probably have enough blood pressure. I believe we're a quarter of the way through this presentation. This is a long chapter. Weak or absent peripheral pulses indicate decreased perfusion, right? The body's shunting the blood away from the extremities. Tachycardia, early sign of hypoxia. Remember, it's all about airway and breathing for these little monsters. So if they're not breathing well enough, their heart rate's going to go up to compensate. Interpret pulse within the context of overall history. So you need to get a patient history, and you need to focus, not focus, but include their personal history, medical history, with the assessment findings you have. Evaluate trend of increasing or decreasing pulse rate. So this is why we want to get vitals early and often to see if there's any trending, any differences, any changes taking place. Feel the skin temperature and moisture. Remember, cool and moist is a sign of shock. Hot and dry is the sign of both fever and environmental hyperthermia. And capillary refill time, take a look. Is it slow or is it fast? We don't care the exact number of seconds, but we want it to be within a second or two at the most. Disabilities. The AVPU scale is their GCS or alertness disabled. Pupil response. Symmetric movement of extremities. Can they move everything equally? Is their strength equal bilaterally? Pain is present with most types of injuries. So let's learn about the pain. Assessment of pain must consider developmental age of patient. So you're going to assess their pain differently according to what age they are. You're going to go into a bit more detail if they're older than if they're younger. Your itty-bitty baby is pretty much only going to be able to cry or not cry. Your 3-year-old should probably tell you how bad it hurts. Generally, if it hurts at all, it hurts really bad, but just the same, they can tell you. Caregiver to remove some patient clothing so you can actually see the human body itself. Avoid heat loss, try to keep them covered as much as possible, as soon as possible. Be aware that being cold is a big deal for a little kid. You ever wonder why your 2-year-old refuses to take a bath during the winter? It's because the minute they take those clothes off, they're freezing. And the minute they get out of that nice warm bath, they're freezing, and they don't like it. So we need to try to keep them warm throughout the call, not just during transport, but throughout the call. Transport decision. Should I stay or should I go now? If I go, there will be trouble, and if I stay, it will be double. It's a Ramon song, one of my favorites. Determine whether rapid transport to hospital is indicated. It's indicated if they have a significant mechanism of injury, if there's a history compatible with serious illness, so they have a history of being ill. Physical abnormalities are noted, potentially serious anatomic abnormality. So let's say their arm is fractured and obviously deformed. Well, that was loud. That would be the sign of a problem. Significant pain. They have real owies. Abnormal level of consciousness would also be an indication of a real problem. And if they have an abnormal level of consciousness, we want to hurry up and get them to an appropriate facility. Remember, St. Mary's Hospital has a Connecticut Children's Medical Center emergency department. It's way in the back of the regular emergency department.
14 is going to be at Patriot, 376 Ocean Road.
Sarah and her partner are going to the altered mental status at the dementia wing of a local not-so-care skilled facility. Gotta love that. Altered mental status of the severely demented.
920.
So we need to consider the type of clinical problem. What's actually going on? Why did they call the ambulance? Will there be benefits to ALS treatment? What are your local EMS protocols as far as how to care for pediatrics? What's your comfort level? Are you afraid to go to the actual pediatric center because it's too far away? And what's your transport time? What help will you need with a long transport time? If the patient's urgent, initiate immediate transport to the closest appropriate facility. And for us out here in the country, the closest appropriate facility is generally the closest facility. Those of you transporting to New Milford might have an additional, what's the word, not disability, but additional constraints on being able to go to New Milford, because quite frankly, they don't want any actually sick patient going there, especially a child. Less than 40 pounds, they need to be in a car seat. I will have a video of an ambulance crew putting a car seat in their ambulance, and you know how long it takes to really do it right. It is a pain in the ass. There's no way around it. It's difficult. And it does a great job, better than reading them. We should always use the patient's own car seat whenever possible. If they were in a severe motor vehicle crash, collision, and their car seat is not in good order, that's a horse of a different color. But unless there's major signs of significant damage to the car seat, then we should keep them in their own car seat. All ambulances should have some sort of pediatric restraint device, like a, what do they call it? I can't think of the name of it, but there's like basically fabric car seats that attach to our stretcher, and they're specifically designed for the ambulance. But every ambulance is required to have some sort of pediatric restraint system. We're always better off using the patient's own car seat. You should be familiar with what car seat type material you have on the ambulance. Most, if not all, ambulances now have a car seat built into the captain's chair, and you might need to transport your toddler or older on that, if at all possible. If they're not too sick and you could manage them in a seated position, that might be your best bet. Follow manufacturer's instructions to secure car seat and captain's chair. I don't know if you know or not, but I'm a certified child passenger safety technician. This is also something that I wanted to do with you guys, was how to properly install a car seat. Patients who require spinal immobilization, immobilize on longboard or other suitable spinal immobilization device. Remember, spinal mobile restriction protocols in Connecticut, we use a backboard as little as possible, and that goes the same for children. Some of our ambulances have pediatric size backboards, which are actually quite effective, and they're generally padded, so they're not as aggressive as our regular longboard. And it's saying here you should not use the pediatric patient's own car seat for spinal immobilization. If they're in their car seat and you're worried about spinal issues, a towel roll around their neck and leave them in the car seat, in my opinion, is a very good way to go. As they get older, that's a little bit more difficult. Most of your booster type seats do not do a good job of securing the cervical spine. History information for an infant, toddler, or preschool age child will be obtained from the caregiver. I mean, that's just the end of it. You cannot ask a 3-year-old about their medical history. Unless they have something very significant in their medical history, they're not going to be able to answer that. Questioning the parents or child about the immediate illness should be based on the child's chief complaint. So, is it an OWI somewhere where you're going to get the best information from the patient? Then go that route. If it seems to be something else, or really with any of these kids, we should involve mom and dad and whatever caregiver's on scene entirely anyways, and ask the child as well. Even if you don't think the child's going to give you any useful information, you should still make the child feel like their opinion matters and ask them and ask the parent. It's always a good plan to ask the child what's going on and then also ask the parent what's going on. You're going to get pretty good answers if you involve both the patient and the caregiver. I did it again. I was paused. I forgot to unpause, so let's start this one again. The nature of illness and the mechanism of injury definitely matter. Length of sickness or injury matters. Key events leading up to this matter. Is it an illness? Were they around other people with an illness where we know what illness the other people had, and now this kid's presenting the same way? Or were they swinging and the swing set flipped over and they flew through the air and landed on their head? That matters. Fever really matters. Remember, a fever over 104, you should expect seizures, and seizures are bad. Effects of illness or injury on behavior. So how is the child behaving? Do they have that vacant stare? Are their muscles flaccid? That kind of thing. Their activity level. Are they moving around like normal? Are they eating like normal? Are they playing like normal? Or is all that stuff decreased? Or is just one thing decreased? Urine output's huge, right? We want to make sure the kidneys are working. A lot of severe infections will affect urine output, so we need to be aware of that. Does this kid normally drink, a half gallon of water a day like Poop does? Or, and are they now only drinking a couple sips? Or the opposite? I mean, you might have a kid with early onset diabetes who's, 3 days ago would have maybe a cup of juice and 1 cup of water a day. And now they're like constantly begging for water and they're pissing like a racehorse. It's because they're in diabetic ketoacidosis. Yes, it could happen to a 2-year-old. Bowel and bladder habits. Most parents are very tuned to how often their child poops and pees. Vomiting, diarrhea, abdominal pain, these all matter. Rashes are very telling of different infections. Name and phone number of caregiver if they are not able to come to the hospital with you. If you have a little kid, that caregiver should go with you. Not next to you, not in the back of your ambulance, but sitting up front in the passenger seat. They should go with you. If it's a really little kid, the kid's got a high degree of stranger danger or anything like that, then we should consider having the mom or dad or caregiver that they trust and love in the back of the ambulance with you. It is legal as long as they are restrained. I mean, put them on the bench next to the kid and put a seatbelt on them. It counts, and that is legal. For the most part, us ambulance providers don't want family in the back of the ambulance because it creates one more person we have to manage. So it's a lot easier to manage them if they're sitting up in the passenger seat. But it's the lead caregiver's decision, and it's a decision they need to make every time they have a juvenile patient. Sample history is the same. We're going to run through the sample like we do for every other patient, regardless of age. We are going to tailor the questions based on the age and the developmental stage. Sometimes you go through your sample and you've been doing this a while, and you ask your questions the same way every time, and you realize you're asking a question that just doesn't pertain to this little kid. And then you point out, oh yeah, that doesn't matter here, and you move on to the next. Onset, provocation, quality, radiation, severity, and time. Again, exactly the same, but tailor it for the age. Physical exam, secondary assessments of the entire body should be used if the patient is unresponsive or has a significant mechanism of injury. I don't need to say any more on that. DCAP BTLS should be used for all full assessments of every patient regardless of age. Focused assessments on patient without life threats, focus on the affected area of the body or the specific injury, focus on the chief complaint. If they're saying their belly hurts, you probably don't need to do a full assessment of their upper back, but you certainly do of the belly. Don't be afraid to put your stethoscope down there and listen for bowel sounds if they're complaining of severe abdominal pain. Find out when the last time they pooped was. We need to remember that constipation is a very large issue for a very young child. Where are we here? Start at the feet and at the head for your physical exams. You could do head to toe once the patient seems to be mature enough for you to start right in at the head. That is a decision you need to make based on your patient, not specifically on a chart that says at age 10 you could do it this way. But tailor it. Get a feel for the kid and see what they'll be most comfortable with and go with that. Head, bruising, swelling, hematomas. Assess the fontanelles in the infant for any signs of swelling or sunken. And if the fontanelles are sunken, the kid's probably really dehydrated. Nasal congestion and mucus can cause a great deal of distress. Your under 1 year old patient that is suffering from a stuffy nose could every once in a while try to breathe through the nose and forget to breathe through the mouth and basically suffer a severe case of dyspnea just because they're trying so hard to breathe through the nose. That's what they want to do. Our bulb suction, catheter suction is very helpful. I know we had a bulb suction with like a hose on the back side of it. It was like a straw, a rubbery, flexible straw, and it had a mouthpiece on it. So you'd put the suction bulb in their nose. It had a little filter on it that was replaceable, and you'd literally use your mouth vacuum to suck the crap out of their nose. The thing worked great. It was a wonderful tool, and it helped all three of my kids a great, no, Colt, we didn't have it for him. I think we got it for Phoebe. Maybe it was just Harper. I don't know. It definitely worked wonders with Harper. Ears, any drainage from the ears is definitely a sign of a problem. Skull fractures are a real concern. Remember, their skull's not that hard. Battle signs, just like an adult. Pus, and pus is not our friend. We need to be aware of that. And mouth, look for active bleeding, loose teeth, smell, note the smell of breath. The same issues for DKA could be present in a little kid just like an adult. So that acetone, fruity smell is something you need to look out for. If they have loose teeth, figure out if it was loose because they're losing their teeth and getting their big kid teeth, or if it was from a traumatic injury, an acute onset of loose tooth. Physical exams, neck, you're looking for the same stuff: swelling, bruising, tracheal deviation. Cannot move their neck and has a high fever. What's that the sign of? Maybe meningitis. That would be a concern. Chest, same thing: penetrating trauma, lacerations, bruises, rashes. It's all the same. Adult, child, it doesn't matter. Look for those injuries. Clavicles and every rib for tenderness or deformity. If you poke on it and they say owie, and there's a little bit of swelling or discoloration, they probably fractured something. Remember, kids don't get clean breaks all that often. They're the green stick breaks where things like splinter, and you need to worry about what those splinters are digging into. Inspect the back for the same stuff. Rashes, there's a lot of bacterial infections that will present with a rash on their back or their abdomen, and we need to be aware of that. And the only way to be aware of it is to look for it. Abdomen, palpate, watch for guarding and the tensing of muscles. Note if it's tender, note if you feel any masses. Look for seatbelt abrasions and bruising in the motor vehicle collision. Note how their car seat was on them, assuming they're still in the car seat when you get there. Was it tight enough? Were the top bracket in the correct place over their sternum, where the seatbelt's tight enough is a big one. If the belts on their car seat were loose, there's a much greater tendency for severe injuries. Check where those abrasions are, the seatbelt burns. If it looks like they're really high on their abdomen, then we need to worry more about liver and spleen. Assess for asymmetry, right? Nature-like symmetry. So apparently I've done it again. Extremities assess for symmetry. Compare both sides for equal size, equal warmth, swelling. If one seems bigger than the other, that's the sign of an injury to the bigger one. In general, find out if they have some rare disease that causes one arm to be bigger than the other or shorter than the other. Watch the patient's eyes and listen to their voice if you put them through a full range of motion. If they start to scream, "Owie," please stop. Don't keep doing it to see how far you could go. But any pain that's noted, you need to stop moving the joint and then secure it. You need to splint it. Vital signs, equipment used to assess adults might not work for your little kids. An adult blood pressure cuff probably isn't going to do a good job on a little kid. Normal heart rates will vary with age. You need to know them. There's a chart in your book. You really need to pay attention to it. Blood pressure is usually not assessed in patients younger than 3 years old. 1, the numbers are too close together. 2, they're really low. I mean, 80/60 for a blood pressure isn't abnormal for a 1-year-old. So what good's going to come of it if you checking it? And there's a good chance you're not going to hear it anyways. So yeah, don't focus on that. Skin assessments is extremely. Just stay in here, Mary, where you're safe. Vital signs. Skin is the best assessment. Is their color good? Is their skin temperature good? Is their cap refill good? These are all really the best way to tell if your child patient is breathing well, if their heart's working well, and if there's any complications. It is important to use appropriately sized equipment, and sometimes we don't have that. First responders, you're not going to have pediatric sized stuff unless you get it because you have young kids of your own. A cuff that covers 2/3 of the pediatric's upper arm, 2/3, and your pediatric cuff should do that. Formula, huh? So sure, feel free to know this. 2 times child, 70 plus 2 times. Yeah, I don't know about this whole formula thing. I don't know. I don't think it's something you'll be tested on. Maybe you should know it just to be sure. Respiratory rates may be difficult to interpret. Yes. Counting 60 respirations in a 4-month-old is going to be really difficult. Younger than 3, evaluate respirations by assessing the rise and fall of the abdomen. Absolutely, it's very apparent when they breathe in and when they breathe out. And do that. Sometimes putting your hand on their chest, if they don't mind, is a great way to help you count the respirations. But again, go back to their skin. Is their color good? Are they responding appropriately? If all that stuff is right, then they're probably breathing good enough. If there's accessory muscle use, if there's noisy breathing, if there's cyanosis or any other signs of dyspnea, then we could assume that they're not breathing good enough, and we need to see if there's something we could do about that. So pulse rate for counting at least 1 minute, it's really necessary. I mean, the chance of your child patient staying still long enough for you to do that are pretty slim. Try to get as close to that minute as possible and then do whatever math you need to. Remember, 30 seconds of assessment, multiply it by 2 for your number, 15 seconds, multiply by 4, 6 seconds, multiply by 10. So you have options, but a full minute of counting and feeling is the best method. Respirations first. Remember, children are airway driven. Respirations matter more than anything. Then the pulse is secondary and blood pressure is a distant third. Pupils, definitely check pupils. You could tell a lot if they're sluggish. Kids' pupils should work very quickly and be quite equal. And you need to be aware and check. If they're not, we need to know. Pulse oximetry, if you could get them to keep that little probe on their finger, it's a great tool to use. Reassess, 15 minutes for stable, 5 for unstable, just like adults. Continually monitor respiratory effort, skin color, and condition. These things will change. They will change rapidly, they'll change steadily. You need to be aware. Keep an eye on their level of consciousness and how much they interact with you. So let the parents and caregiver assist. If they're calm and collected, let them ride in the back of the bus with you. If they're an absolute wreck, get them away from you. Well versed in their child's medical conditions, especially if the child has medical conditions. A loving parent or caregiver will know their medical history as well as the doctor people do. Oxygen or nebulizer administration. We don't get to do nebulizers at the BLS level here in Connecticut. Hopefully someday we will, but at this point we won't. And really at this point with the COVID thing, nobody's getting nebulizers in the ambulance, so it's kind of a moot point for now. Communicate and document, just like everything else. Communication, documentation. Respiratory problems are the leading cause of cardiopulmonary arrest in the pediatric population. We need to understand this. Respiratory failure causes cardiac failure 9 out of 10 times. Patient must work harder to breathe and will eventually go into respiratory failure if left untreated. Kids get tired. They could only breathe really hard and fast for so long. Note changes in behavior. Are they combative? Are they restless? Do they seem really anxious? This is all generally a sign of difficulty breathing. This stuff was mentioned like 46 slides ago, but signs and symptoms of increased work of breathing. Nasal flaring is a big one. Abnormal breath sounds, accessory muscle use, and tripod position. Those are the things we're looking for.
Transporting 1 Charlie to Charlotte, beginning miles 802, 83 even.
So their effort to breathe gets slower. They're working less hard. It's generally because they're starting to fail. They're tired. Chest rise is less. So remember, just looking at their chest or feeling it, chest rise and fall tells us a lot about their breathing. If it's starting to get less, we need to note that and do something about it. So they've used up all their energy, and there comes a point where they just cannot do it anymore, and they're going to stop altogether. Without care, cyanosis will develop. You need to make sure that they stay, oxygenated. Let's go with that. Changes of behavior, altered level of consciousness, the vacant stare, becoming flaccid as their muscles become hypoxic, and then their heart becomes hypoxic, making it slow down, and then you have to start CPR. So heart rate less than 100, or less than 90, less than 100, less than 90, less than one of those. Look in your book, figure it out, make sure you know for sure. You need to assist their breathing. A heart rate less than 60. For infants, you need to do full CPR. Respiratory failure, it does not always indicate an airway obstruction, but you need to rule that out quickly. Conditions can progress from respiratory distress to failure at any time. Child needs supplemental oxygen, give it to them. Possible respiratory failure, assist ventilations with a BVM and 100% oxygen. For these itty bitty kitties, 100% oxygen is really important, or at least supplemental oxygen. Remember, our adults, we could bag for a while just on room air and it's still going to help them. Kids really need that extra oxygen. And try to keep them comfy. Comfort does matter. Obstruct airway with any object that fits in their mouth. Remember, their mouth is big enough for their whole fist. Trauma, teeth may have been dislodged into the airway, and a tooth in a little kid could be enough to block the airway, especially if it's an adult tooth. Vomit, secretions, blood, it can all obstruct the airway. Infections can. Congestion, fever, drooling, cold symptoms, stridorous cough, barking cough. We need to assume that there's some sort of infection. Croup is an infection in the vocal cords. The vocal cords swell up and block the airway. Epiglottitis is an infection of the epiglottis above the level of the vocal cords. They could swell up. Epiglottitis is generally considered a more severe life-threatening condition than croup. There you go. There's a nice little swollen airway. Obstruction by foreign object may involve upper or lower airway. So there's no telling where this obstruction happened. Partial airway obstruction, decreased breath sound, stridor. Complete airway obstruction, just like adults, no breath sounds whatsoever. They're going to become rapidly cyanotic because they're not getting any oxygen. Lower airway obstruction, wheezing, crackles. So listen to breath sounds at the armpit level, both sides, front and back. Begin treatment of airway obstruction, encourage coughing. If they only have a weak cough, then you need to do the abdominal thrust or chest compressions, whatever you can make happen. Allow them to remain in a comfortable position. Be prepared to do CPR when they stop, go unconscious. So severe airway obstruction is an ineffective cough. So they're still kind of coughing, but it's not strong enough to move anything. Not able to speak or cry, respiratory difficulty, stridor, cyanosis, and eventually loss of consciousness. Position them face down. We did all this in CPR training. I'd like to do this again with you. Back and forth, back blows to chest thrusts until they become unconscious or the airway is clear. If they become unconscious, you do CPR. Yep, until the airway is clear or they're unconscious. You're going to keep doing it. Head tilt, chin lift, finger sweep. If you could see the item, no blind finger sweeps, please. Chest compressions to relieve it. Heimlich maneuver if you can. Slapping them on the back as long as you could flip them over and get their head lower than their stomach. You need gravity to work with you on that. Asthma, the bronchioles swell. Very common, especially in children. Respiratory infection, exercise exposure to cold air or smoke, and emotional stress could all trigger asthma. Environmental exposures as well, like allergies can cause asthma. Wheezing on exhalation is generally asthma. It is, the wheezing happens as the lungs are forcing the air out. Cyanosis and respiratory arrest will develop quickly. Tripod position makes it easier to breathe. If you find them in a tripod position, you need to find a way to transport them in that way if it's giving them any relief.
14.
Position of comfort, supplemental oxygen, bronchodilator, like a metered dose inhaler if they have it. We do not carry them. We cannot give them at the basic level. We could assist. Hopefully they have a caregiver there that could also assist. Don't squeeze the bag hard and fast if you have to ventilate the patient. Remember, slow, steady, and just enough air to rise the chest. A prolonged asthma attack is a true emergency. high flow oxygen, rapid transport, ALS assistance are all good ideas. Exhausted and stops trying to breathe, you need to manage the airway and breathe for them. Positive pressure ventilations with your BVM and get ALS. You are going to want help. Pneumonia is a leading cause of death in children. General term that refers to an infection in the lungs, generally the lower lungs, often a secondary infection. The infection started somewhere else and ended up pooling in the base of the lungs, and then it gets worse. Immunodeficiency in children are at, of course, a higher risk for any kind of infection, and the incidence is greatest during the fall and winter, just like for. So our presentation, what are they going to look like? Rapid breathing, grunting or wheezing sounds, nasal flaring, tachypnea, fast breathing, rapid breathing, right? Didn't we already say that? Hypothermia or fever, and diminished breath sounds or crackles over the infected lung segments. Unilateral means one-sided. Generally, pneumonia is only on one side. It's not both. I mean, it could be double pneumonia. That's a real serious problem. Pediatric patient treatment, supportive care, monitor airway and breathing status, administer supplemental oxygen, bronchodilators if you're able to, if they have their own inhaler. Do not give them somebody else's inhaler. Even though it'll probably help, it will get you in trouble. Diagnosis has to be done by a hospital. Chest x-ray, blood work. Croup, infection of the airway below the level of the vocal cords, usually caused by a virus. Seen in children ages 6 months and 3 years. How about 6 months and 8 years, like Colte had? Actually, he started at, he was 3, almost 4. Maybe it was 4 to 8. 4 years of miserable croup. Starts with a cold, cough, and a low-grade fever and develops over a couple days. The stridorous, seal-barking cough is your biggest sign of it. Humidified oxygen, which guess what? We don't have. A lot of medics will have them nebulize saline with great effect. Bronchodilators are not indicated for croup because it's not a problem in the bronchus or the bronchioles. It's a problem in the airway. The definitive solution is nebulized epinephrine, norepinephrine, or racemic epinephrine. Racemic epi is the best one. And then steroid like Decadron for the long-term control. That's stuff that we do not have at the BLS level. Epiglottitis is generally a bacterial infection above the vocal cords. Decreased since there is a vaccine for the bacteria that causes it. It could swell the area 2 to 3 times normal. Child will look ill, sore throat, high fever, tripod position may be helping them. They might be doing a lot of drooling because they can't swallow. Bronchiolitis is specifically caused by a virus, RSV. I think it's rhino something or other virus. Highly contagious, spreads through coughing or sneezing, just like our corona. Survive on surfaces for long periods of time, just like corona. Tends to spread rapidly through schools and in child care centers. For the most part, our adults don't really get this. They tend to just be able to fight off this virus a lot better than our young children. So bronchiolitis is a lot more common in premature infants and results in copious amounts of secretions, which they could then choke on or aspirate and get pneumonia. First 2 years of life, almost always in boys. I don't know why. Widespread in winter, early spring, just like all our other viruses. Inflamed, swollen, filled with mucus. Very difficult to breathe. Dehydration, shortness of breath, fever are your signs. Calm demeanor, just like every time you approach a child. Keep the patient in the position of comfort, generally sitting up, being held up. Treat airway and breathing problems. Humidified oxygen is helpful but not available to you. ALS backup, for sure. These little kids, don't mess around. Don't be afraid to call a medic. Whooping cough is currently coming back due to a large population of Central Americans where they do not provide immunizations for it. And then there's this big push for kids not to get immunized, which I will never understand. But those kids are then coming into contact with immigrant children who are carrying whooping cough. And then because the American children haven't been immunized to it, they're getting it. Loud, crazy, painful coughing, sneezing, runny nose, whoop sound during inspiration. Infants may develop pneumonia or respiratory failure secondary to pertussis. Keep the airway open, transport rapidly. Remember, it's contagious if you're not vaccinated for it. There's a very effective vaccination. Pertussis was eradicated in America until the last 5 years or so. We had virtually no cases, maybe 1 or 2 nationwide up until you need to wear a mask and eye protection just to make sure. Airway adjuncts could help providing artificial ventilation, oropharyngeal, nasopharyngeal. Bite blocks, I'm not exactly sure. I mean, that's like the old bite stick and you put it in there between their teeth to keep the airway open. I would not recommend that. Your nasal or oral airways are your best bet. And of course, breathe them with the Bevum. Oral keeps the tongue out of the way. Unconscious, in respiratory failure with no gag reflex. Should not be used with a caustic, petroleum, or petroleum-based product. So we need to be aware of that. If it seems like it's poisoning, we should not use an airway. Nasals are generally well tolerated. They're just a little annoying for responsive patients. Again, used for possible respiratory failure. Rarely used in infants younger than 1. Should not be used if there is nasal obstruction or head trauma. That is for adults as well as children. It should not be used if there is nasal obstruction or head trauma. Nasals might get filled with mucus, blood, vomit, or other soft tissues of the pharynx. You can suction them out quite effectively with a French suction catheter. They might cause the spasm of the larynx if you put one in that's too long. Again, facial trauma. Any facial trauma, you do not want to put anything in nose holes. Blow by means holding a mask close to their face and letting that oxygen blow through it. You could flow it higher than 6. You could go really up to 10. It might provide them with a little bit more. A nasal cannula will do a pretty good job if you could get them to leave it in their nose holes. And a non-rebreather mask is your best option short of the BVM. You should be, rewind to that last slide, you should be aware of those percentages delivered. That is really a thing. The non-rebreather is more like 85% than 95%, but hey, at least they're not calling it 100% anymore like they did when I first took the class. Where are we here? Adequate respirations and tidal volumes. So if they're not breathing good enough, you need to help them. Respirations less than 12 or more than 60. So that's a range. Below 12 breaths per minute, you bag them. Above 60, you need to try to bag them. If they're breathing more than 60 breaths per minute, they're not going to be breathing adequately to actually sustain life, which would be considered inadequate tidal volume. Obviously, blow-by is less effective, but it's still better than nothing. Kids might tolerate it a lot better. Place tubing through the bottom hole of a cup. Connect tube to oxygen. Hold cup 1 to 2 inches away from nose and mouth. The best way to do it for us is to just use a non-rebreather and hold it 1 to 2 inches away from the nose or mouth. Patients might tolerate the cannula and it might work well. We should have pediatric size cannulas on the bus, and you should use those. NRB, again, you could only suck in oxygen and then you could exhale like normal because the little valves open up when you breathe out. Select appropriate size mask. If you don't have a child mask, I mean, you should have a pediatric size mask and an adult on the ambulance. Adjust the flow rate to accommodate them. For a pediatric, you might not need 15 liters a minute. You might not even need 10. 8 might be plenty to supply them. You should go with 10. If you're the first responder and you're concerned about having enough oxygen to last, and you put them on 8 liters and that reservoir bag is not completely depleting, then you'll be okay. But in general, we should not do anything below 10 liters per minute with a non-rebreather mask. Again, we use the BVM for too fast or too slow breathing if they're unresponsive, if they do not respond to painful stimuli. Appropriately sized equipment, maintain a good seal with the mask on the face, ventilate at the appropriate rate. Remember, slow, gentle squeeze, just enough to get chest rise. Remember that the BVM was designed for 2 people. You will do a much better job if there's 2 of you managing the BVM. Cardiac arrest in the pediatric is almost always associated with respiratory failure. Adult becomes hypoxic, develops dysrhythmias, which leads to sudden cardiac death. Children become hypoxic and their hearts slow down, becoming bradycardic and eventually stopping. Shock. We know shock. We've gone over shock. Shock comes up in all these different presentations. Compensated is the earliest stage. Decompensated is the later stage. We need to recognize that they're in compensated shock and do something about it before it becomes decompensated. When the child becomes decompensated, death is close by. Traumatic injuries with blood loss is a common cause of shock. Abdominal trauma. Dehydration from diarrhea and vomiting, very severe infection causing septic shock, neurologic injury, severe head trauma or neck trauma could cause neurologic shock. Allergic reaction, anaphylaxis, diseases of the heart, underlying comorbidity, collapsed lungs due to a tension pneumothorax, blood or fluid around the heart, which we call a cardiac tamponade, and pericarditis. Those are all causes of shock for a little kid. They respond differently to fluid loss. They'll increase the heart rate to try to compensate. They'll increase the respirations to try to compensate. They'll start to shunt blood away from the extremities. They'll be pale or cyanotic. Signs of shock, tachycardia, fast heart rate, cap refill times greater than 2 seconds, mental status changes are all signs of shock. Treat by assessing ABCs and intervening as necessary. Circulation first if there's any chance of bleeding or if cardiac arrest is suspected. Remember, we go right to compressions for cardiac arrest. Pediatric patients do not demonstrate a fall in blood pressure until shock is severe. Again, our pediatric patients, we don't really care about blood pressure. It's not telling us enough. Assess the rate and quality of pulses, temperature and moisture of hands and feet, the skin color, cap refill time, with 2 seconds being normal. Less than 2 seconds is preferred. Changes in pulse rate, color, skin signs, and cap refill suggest shock. This is where, you know, our initial baseline vitals as early as possible will help us see if they're trending down. Blood pressure is difficult to measure. It's not going to give you much information. Include talking with the parents and caregivers during your assessments. Absolutely imperative. Management should be simple interventions. Don't waste time performing anything complicated. Ensure airway is open and prepare for artificial ventilation. Be ready to start bagging these kids as soon as they need it. Obviously, control the bleeding. Supplemental oxygen by mask or blow-by. Continually monitor the airway and breathing. Position for comfort. Keep them warm. Keep the heat on. Immediate transport, ALS backup. Anaphylaxis. Airway swelling and dilation of blood vessels. Common causes are insect sting, medications, or food allergies. We know how to treat for anaphylaxis. We use epinephrine. 0.15 milligrams of epinephrine. Signs and symptoms of anaphylaxis are the same as all other, well, okay, so I should take that back. Stridor and wheezing could be a big one. Work of breathing, altered appearance, restless, agitated, and they have that sense of impending doom. You have a 3-year-old saying they're going to die. It's because they're really scared they're going to die. Hives are another big one. What's the technical term for that? Do you remember? I'm drawing a blank. Moving on. No, I can't think of it. Maintain airway, administer oxygen, allow caregivers to assist in positioning oxygen delivery and maintaining calm. You have to make sure that caregivers stay calm. Assist with the auto-injector epi or the check and inject like I taught you in class. And provide rapid transport. You don't want to hang out with these kids any more than you have to. Hemophilia is the same for adults and children. We went over this in whatever class we went over it in. All injuries are serious physical injuries because the blood does not clot. Here's another mnemonic that I guess might be helpful, so definitely take a look at it. Simple confusion, a coma, oh my gosh. If level of consciousness is low, patient may not be able to protect the airway. That's our biggest concern, right? Airway, get them to the hospital. Give them oxygen, maintain their airway, and get them to the hospital. Seizures, just like adults, they might be subtle, they might be severe. Here are some common causes of seizures. Seizure disorder is the biggest, easiest to understand. Fever and poisonings are the next two most common. Postictal state, you need to be calm, you need to be slow, you need to be patient. Status epilepticus is seizures continuing more than 30 minutes. This is a life-threatening situation. Protect them and request ALS backup. Your paragods can provide medications to stop the seizures. Secure and protect the airway. Position the head, clear the mouth with suction. Recovery position if the patient is vomiting. Remember, that's the left lateral. Oxygen by non-rebreathing mask or blow-by, whatever they'll tolerate. BVM if they're not improving and not breathing adequately on their own. So we're going to ignore this because we are not allowed to do rectal doses of diazepam in the field. We're not allowed to give that at all. The family might be able to do it. If it's a medication they have and they have not given it yet, please encourage them to do so prior to transporting the patient. Inflammation, meningitis, inflammation of the tissue covering the spinal cord, caused by bacteria, virus, fungus, and parasites. Brain damage or death if it compresses the spinal cord and brain too much. Being able to recognize it is important. Newborns, males, those with AIDS, cancer, or other immunodeficiencies, history of brain, spinal cord, and back surgery, children who have head trauma, shunts, pins, or other foreign bodies in their brain or spinal cord, and especially children with, I forget what VP is, but it's a shunt that's in their brain. Fever and altered level of consciousness are signs of mild headache to inability to interact. Children may experience seizures. Under 3 months, you could see apnea, cyanosis, fever, distinct high-pitched cry, or hypothermia. So it's a wide range. Meningeal irritation are terms to describe pain that accompanies movement. So you move them around. A stiff neck is a big sign of a problem for meningitis. Increasing irritability, bulging fontanelles without crying are also signs. The bacterial meningitis, which generally it's not called Neisseria, it's called bacterial meningitis. Shock and death will occur rather quickly. Small pinpoint cherry red spots or large purple-black rash. Serious risk of sepsis, shock, and death. So there's the rash. Contagious. We should assume a possible meningitis patient is extremely contagious. It doesn't seem to be mentioning it here, but our largest age group for meningitis is college age people. I know at that point we're not supposed to call them kids, but I wouldn't quite call them adults. But just to say, it's that college age group where they're living in dormitories, and this will spread through like wildfire. Supplemental oxygen, assist with ventilations, reassess. If you have any suspect that meningitis is the culprit, you should be wearing a non-rebreather, an N95 to protect yourself. Never take, where are we? GI emergencies and management. Oh my gosh, this just keeps going. I need a break. So GI complaints are very common in our pediatric patients. Monitor for shock, it is a possibility. GI origin are common in patients. Ingestion of certain foods or unknown substances are a concern. Patient will experience discomfort, nausea, vomiting, diarrhea, which could cause dehydration, which could be a very serious concern for a pediatric patient. Appendicitis is also common, lead to peritonitis or shock. Typically present with fever and pain upon palpation of the right lower quadrant. You should commit that to memory, not so much for testing, but for testing, and even more than that for actual patient care. So yeah, be aware of that right lower quadrant pain and fever. Generally the pain starts slowly and works up to where it's unbearable, and that's the point at which they call us. Rebound tenderness is common, so you could press on it and it doesn't hurt too bad, but when you release that pressure, that's when it hurts. You want to move quickly. This, by the time they call us, it's already severe. You need to move quickly. Obtain a thorough history. Figure out the diaper situation. Are they drinking? Are they able to keep it down if they do drink? How long have they had diarrhea? How severe is the diarrhea? Are tears present during crying? If they're crying without any tears, that's a sign of extreme dehydration, which is an emergency situation. Poisoning is huge. Ingesting is the most common. It's the most common. Absorbing would be next, especially for farm kids. The chance of them getting into a bag of pesticide is quite possible. Alcohol, aspirin and acetaminophen, cosmetics, cleaning products, and houseplants. These are our big concerns as far as poisoning. There's a lot of common houseplants that are extremely toxic to children. Alcohol is obviously extremely toxic to children. Pills of all kinds, but we all have aspirin, Tylenol, Motrin, acetaminophen, all those things. Ibuprofen, which is Motrin. Acetaminophen is Tylenol. Oop, I was recording through a kiss. Sarah just got back from her call. Household cleaning products are another one. A lot of this stuff tastes awful and kids won't actually eat that much of it. Some cosmetics taste really good and they will eat a lot of it, and there's no telling what's in that crap. Common sources of poisoning: iron. So I guess a lot of children are chewing on wrenches like my kids did, but it never seemed to affect my children negatively. Prescription medications of family member is huge. Illicit drugs is a big problem, and vitamins could be a huge problem. A lot of vitamins have that gelatin coating, the gel tabs, where the gelatin is sweet. So they are more than happy to suck a couple of those down. But if it's a fat-soluble drug, it could cause a lot of problems. Vitamin A, zinc could cause a big issue for the body. What else? Vitamin D, too much of that could cause a problem. The other big thing is gummies. A lot of adults are using gummy vitamins now where they taste delicious. They look, they feel, and they taste like candy. But if it's a good quality gummy vitamin that actually has a whole lot of vitamin in it, it could be severely detrimental to the child's well-being. Signs and symptoms vary depending on substance, age, and weight. That's absolutely true. Some only take one pill to be lethal. You know, a 2-year-old who pops an oxy is probably going to stop breathing. Be alert for signs of abuse. Ask caregiver what substance was involved, how much was ingested, what time did it happen, how has the child's behavior changed, is there choking, coughing, frothing after the exposure. Difficulty breathing is something else to ask about. Poison control center hotline is 1-800-222-1222. 1-800-222-1222. If you think it might be poison, then the first thing you should do is call 1-800-222-1222. Yep, sorry to make you sit through that. But hopefully it will help you remember the number. And you won't have to remember it if you program it into your cell phone. Remove tablets or fragments from mouth. Try to decon them as best as possible. Wash liquid poisons off. Brush dry poisons off the skin. Assess and maintain the ABCs. Monitor breathing. Treat for shock. Transport immediately. Charcoal is still required for National Registry testing purposes. Charcoal is no longer allowed in the state of Connecticut. So we need to remember that it's not for acid, alkali, or petroleum-based products. So acids, alkalis are bases, so it would not be used for a kid who drank some battery acid, which it burns immediately. I don't think they'd do that. It's not for somebody who drank bleach, which is an alkali, and it's not for somebody who drank motor oil. Try to commit that to memory for testing purposes. Not recommended for anybody with a decreased level of consciousness. If their LOC is decreased, they're not going to be able to swallow. Actidose is the one that I always saw. I never saw the other ones. 1 gram per kilogram of body weight. So you need to memorize that, 1 gram per kilogram. And again, you need to memorize that for testing purposes, not for field service, because you're not actually going to do this. Dehydration, fluid loss is greater than fluid intake. Very simple, right? Can lead to shock and death if left untreated. Again, very simple, right? Infants, children, and geriatrics are at the greatest risk. Life-threatening dehydration can overcome an infant in a matter of hours. An infant with severe vomiting or diarrhea could die of dehydration. And it's mild, moderate, or severe. Dry lips and gums, decreased saliva, decreased wet diapers, no tears if they're crying, sunken eyes, sleepiness, irritability, loose skin, sunken fontanelles are moderate. So the first one, I'm sorry, I shouldn't have put in the tears. The tears are severe. Severe dehydration, they are saying mottled skin, cool, clammy skin, delayed cap refill time, decreased respirations, lack of tears when crying. Ew, that's so gross. Please don't do that to your patient. Assess ABCs and obtain baseline vitals. Request ALS. Transport to ED. Fevers above 100.4 is a fever, rarely life-threatening. A fever of 104.4 could cause seizures. That's it. Causes could be infection. That's the most common for us. Status epilepticus, cancers, drug ingestion. Aspirin would be the most common to cause high fever if they've overdosed on it. Which not so much a concern anymore because not so many people have aspirin, but I take that back. What are people with heart conditions taking now? They're taking low-dose aspirin. If a child chews up 3 or 4 of those low-dose aspirin, they now have a regular dose aspirin, which is an adult dose, and their body's too small to deal with it. Fever could also be caused by arthritis, lupus, systemic lupus, erythematosus, rash on the nose, high environmental temperature. So it could be a heat stroke situation. Result of internal body mechanism in which heat generation is increased and heat loss is decreased. This is a whole lot of talking. So where are we? 180, only 100 more slides to go. Yay. Accurate body temp is important for pediatric patients. Rectal temperature is the most accurate for infants and toddlers. Under tongue or arm will work for older children. What do most of us have on our ambulance? We either have the new Exogen temporal scanner, the one that you just rub across their forehead down to the base of their ear, or the tympanic, which we stick in their ear. That's generally the kind of thermometer an ambulance is carrying. We do now carry rectal thermometers for hyperthermia, but they are only indicated according to our protocols for that. If you're in a situation where you're concerned a child has a high fever, you have the rectal thermometer, and the parents were unable to check the temperature, then I don't foresee anybody getting in any trouble for using the rectal thermometer, assuming the patients are on board with checking it. So as long as you're all in agreement, it's a fine plan. Patient may present with I should also mention that rectal thermometer, the ones we should be carrying, are disposable. They should only be a couple dollars each, and they're considered a one-time use thing. So if we have that, we could absolutely use it under the tongue. But then the patient has to be old enough and competent and capable to keep it under the tongue long enough to get a reading. Patient may present with respiratory distress, signs of shock, stiff neck, rash, hot skin, flushed cheeks, and in infants, bulging fontanelles. All this stuff could happen during a fever. Assess for nausea, vomiting, diarrhea, decreased feedings, headache, increased diarrhea or loose stools, increase or decrease in urinary output. You want to be aware of both. Transport and manage ABCs. Standard precautions for communicable diseases should be on your mind. Febrile seizures, generally between 6 months and 6 years, caused by the fever and nothing else. First day of febrile illness, generally tonic-clonic activity in nature, less than 15 minutes with little or no post-ictal state. So they seize, they come right out of it, they're back to just being sick and miserable. It may be the sign of a very serious febrile situation. Assess ABCs, try to cool them down, tepid water, not freezing cold water, prompt transport. Patients with febrile seizures need to be seen in the hospital setting absolutely every time. Ensure your own safety and drowning emergencies now. Children under 5 are at most risk. Alcohol generally is a factor with adolescents. So the 12-year-old gets a hold of a bottle of booze and then they get near the water and they drown. It's a very common situation. Principal condition is lack of oxygen. Imagine that. A lack of oxygen when they're underwater. Hypothermia from submersion in icy water is often our friend. Much better of resuscitating the patients who suffered hypothermic submersion. Diving increases risk of neck and spinal cord injuries, which is why every drowning victim should be assumed to have spinal cord injury. Good signs and symptoms are coughing and choking. AMS and seizure activity, unresponsive, fast, slow, or no pulse, pale cyanotic skin, abdominal distension. Those are all really bad signs. I'll take coughing and choking absolutely every time. The rest of it's a lot more difficult to deal with. Manage ABCs, call for ALS crew if you think they're needed. Give as much oxygen as possible. Cervical collar if trauma is suspected. And remember, with all drowning patients, we're supposed to suspect cervical injury. CPR if unresponsive. Well, if unresponsive with no pulse or breathing. Traumatic injuries are the number one killer of kids. Quality of care can impact recovery. The better the care you give, the faster you deliver them to the appropriate medical facility, the better off their outcome tends to be. Femur fracture is rare, but it is possible, and it's generally messy if they suffer one. Older children and adolescents. I'm not sure if I did this slide yet. Anyways, force of injury affects structures differently. A child's head is proportionally larger than an adult's and exerts greater stress on the neck structures during a deceleration injury. Remember, bowling ball on a broomstick. That head-on collision, the young child is a lot more likely to suffer neck trauma than an adult. This is one of the reasons why we want our children to be rear-facing as long as possible, because most car crashes involve severe deceleration, and the child is safer rear-facing. Psychologically, they're often injured because of underdeveloped judgment and lack of experience. Assume the child has a serious head and neck injuries if there's any signs of mental deficiencies. It's important for you to understand physical and psychological characteristics of children. Vehicle collisions. Children can dart out. You got a call. Psychological characteristics of children. Sorry, I just got back from an abdominal pain call. got to get back into the flow of things. Children could dart out. Yeah, so we need to know that kids could sustain high energy injuries from getting hit by a car. When the car hits them, we should really expect pelvis, legs, abdomen for sure. The head, the whiplash situation, getting thrown to the side towards the vehicle, assuming they're standing sideways when they get hit, could snap the neck or cause fractures as well. And then sports. Quite often they get injured during sports. Wouldn't be the first time we got called to a soccer field for some severe injury. Head and neck injuries, contact like football, wrestling, ice hockey, field hockey, soccer, or lacrosse. All of them are going to present with different injuries. Most likely lower extremities in your soccer, lacrosse, if somebody gets hit with one of those lacrosse ball catcher things, those sticks, I don't know what they're called. Ice hockey, slipping and falling on the ice. Football, obviously head injuries, clavicles are huge in football. Immobilized cervical spine. Be familiar with your protocols for helmet removal. I know we went over that briefly, but that is an important one to know. Not so much for testing as it is for real patient care. We discussed the size of their head. Infants, softer, thinner skulls, easier to have brain injuries. Scalp and facial vessels may cause a great deal of blood loss if not controlled. That's for all age groups. The head is extremely vascular, and bleeding will occur. Nausea and vomiting are common symptoms. Easy to mistake for abdominal injury or illness. Generally, no. We generally know that we're getting called for some sort of traumatic head injury. Any child who experiences nausea and vomiting after a traumatic event, we should assume head injury. We should also be looking for dizziness, blurred vision, confusion, constantly repeating the same questions. Immobilize is necessary for all children with possible head and spinal injuries. Immobilization could be difficult because of the kid's body shape and size. Padding under the torso to maintain a neutral position, that's very important. If we're strapping a kid down to a backboard, we need to make sure we pad the voids and keep them in that neutral position. It may be necessary to immobilize our infants, our toddlers, in car seats. It is a completely acceptable plan. 8 to 10 years, no longer required padding under the torso, could lie supine on the board, but we need to check. If we put them flat on the board and it looks like their head's cocked forward, then regardless of the age, we should pad those voids and keep them neutral. You're probably going to have to do some sort of padding around them to make the straps actually hold them down so that they don't slide sideways. Roll up a bath sheet and tuck it in along their lateral edge between the edge of the backboard and the patient so that they can't move to the side. Chest injuries are generally from blunt trauma. The chest wall is flexible and can produce a flail chest. Remember, a flail chest is, 3 or more ribs broken in 2 or more places. But pediatric patients are managed the same way as adults for that. We need to worry about internal chest cavity injuries, even if there's no signs of them outside. So this is one where, based on mechanism alone, we're going to have a high index of suspicion for internal injuries. Abdominal injuries are very common. Children will compensate well for blood loss until they don't anymore. We can have a severe injury there without external evidence. So you could have a severe internal injury without any bruising, ecchymosis, or pallor on the outside. Monitor children for signs of shock. Try to prevent shock and treat aggressively. Whatever. Burns are the most serious, or considered more serious than burns to adults. More surface area to relative total body mass, greater fluid and heat loss. So this is something we really do need to be aware of. Children do not tolerate burns as well as adults. Colt burnt his finger on the glue gun yesterday, and it was 2 days of, owie, my finger hurts. Why does my finger still hurt? What can I do for my painful finger? What could we do? Ow, why does it hurt so bad? Why does it hurt so bad? Yeah, that was 2 days because of a little 2-centimeter burn. It was a 2nd-degree burn, I'll give him that, to the tip of his index finger, which again does have a lot of nerve endings. Children are a lot more likely to go into shock and become hypothermic from burns. Exposure to hot substances, hot items on the stove, caustic substances like chemicals that will cause chemical burns, and then infection. The burn site is most likely going to become infection. We need to try to keep everything as clean as possible. We should consider child abuse and report any legitimate suspicions. We're not going to report every burn. There's a good chance that the burn was due to the child's own actions, but we need to have a high index of suspicion for a child with burns. Not so much now, but right up until the 80s, scalding burns, cigarette burns were very common as methods of punishment for children. So we need to be aware of that. And our burn severity is minor, moderate, or critical. That's different than the degrees of burn, which are superficial, partial, and full thickness. Yeah, you sent it to me?
No.
Oh. I like that one better. But shouldn't it be striker not approved?
Oh, no. That's better when it's straight.
I take it that's the joke.
Yeah.
My partner's making memes of our striker stretcher with Furno straps on it. All right, back to the lecture. Burns continued. Pediatric patients are managed in the same manner as adults. Prevent hypothermia. Ventilate if they're not breathing good enough, and monitor during a rapid transport. Extremity injuries. Immature bones with active growth centers. The growth plates are at the end of the bones. They are potential weak spots. You're most likely going to get either partial fractures or green stick fractures. We need to be aware of this. We need to do a good job splinting, and we need to get them to an appropriate facility. Injuries to extremities continued. Extremity injuries in children are managed in the same manner as adults. Deformed limbs should be try to get it back into proper position once and splint. You should use child-sized splinting materials. Things like the SAM splint are obviously universal. A lot of the vacuum splints and that sort of thing will work well. If they're just too darn big, then you can't use them. You got to find something else. The padded board splints, the short ones, tend to be good for the child. So just do your best and splint as effectively as possible. First step is recognizing the pain. The patient is in pain. So yeah, that's kind of obvious. You're going to recognize that they're in pain. The Wong-Baker FACES scale. Ultimately, you're going to know if they're in pain. It's going to be fairly apparent without any kind of scale how much pain they're in. Our interventions are positioning, ice packs, and elevation. That's really all we do. They say that it will decrease pain and swelling to injury site. In my opinion and experience, it might decrease pain some. It's really not going to do anything for swelling. Sorry, but it's not. ALS interventions are not a bad plan. If nothing else, get the kids some pain meds. There's no reason they should have to suffer all the way to the hospital. And be kind and provide emotional support. Not my strong point, but even I could do it with some kids. Jumpstart triage system. It basically follows our smart tag triage system, where smart tag is for mass casualty incidents, START is for single casualty incidents, specifically to rate how serious your young child is. So it's all the same. Green is minor, able to walk. Yellow is delayed, meaning they could wait a while. They're breathing fine. They have good peripheral pulses. They're responsive to at least painful stimuli, if not verbal and just alert. Red means you need immediate care. The apnea responsive to positioning or rescue breathing. So if you ventilate them, they ventilate. I don't think it's very helpful. But anyways, breathing but without a pulse, let me tell you that breathing's not going to last for very long. Or inappropriate painful response. And black means that they're dead or circling the drain. Here's our jump start triage flowchart. That's what it is, flowchart. And this is MCI training. I'm sorry, MCI. It's still MCI. Connecticut uses the SMART tag, which is basically the exact same thing. All right, that's enough on that topic. Child abuse and neglect. Any improper or excessive action that injures or otherwise harms a child is abuse. Physical, sexual, neglect, and emotional abuse. 500,000 children are victims. Many children will suffer life-threatening injuries due to abuse. If it's not reported, it's going to continue. You will be called to homes because of reported injury to a child. Child abuse occurs in every socioeconomic status, meaning it doesn't matter if they're rich, poor, smart, dumb. This can happen. Be aware of the surroundings, document any findings objectively, and ask yourself, is the injury typical for the age of the child? Is the mechanism reported consistent with the injury? Is the caregiver behaving appropriately? Does it appear that there's drinking or drug abuse happening there? Did they delay seeking care? Is there an apparent good relationship between the child and caregiver? Does it seem like there's some heavy tension between them? Will the caregiver not let the patient talk for themselves? Are there multiple injuries at different stages of healing? So you get called for the broken arm and you see some bruising that looks several days old, and you see some burns that have scabbed over. And there it is. Bruises or marks caused by cigarettes, grids, or branding injuries. Are there several types of injuries? Any burns on hands and feet that involve a glove distribution? Meaning like the entire hand, full circumference, like their hand was put in burning water, scalding hot water. Is there unexplained decreased level of consciousness? Is there and an appropriate weight? Any rectal or vaginal bleeding? Is the home clean, dirty, disheveled, stacked with stuff? Is it warm? Is it cold? Is there signs that there's food? Here's another child abuse mnemonic that may help you, or it might not. Certainly not a bad idea to commit that to memory, but it's certainly not required. Bruises. Observe color and location. We should all know how bruises look when they're new or when they're old. They'll turn blue, then green, then yellow, then brown, then fade. This is something you should be aware of. Bruises to the back, buttocks, or face are suspicious and usually inflicted by a person. Not too many people get a major bruise to their back without somebody helping them get it. Burns to the private areas, almost always. Nobody does that to themselves. Look like a glove inflicted by someone else. Suspect child abuse. Remember, we are required reporters. If there's any sign of abuse, then you need to report it. In general, the best way to start it, day or night, weekday or weekend, nights, holidays, is called 211. And when you get somebody on the line, tell them that you're reporting a possible case of abuse or neglect. And they will tell you how to actually report it. But you are required, you are not able to assume that somebody else is going to do it. If you have a 3-person crew, not all 3 people have to report it, but all 3 people have to make sure that one of you report it, and it should be the lead caregiver. If you are uncomfortable reporting it to the state yourself, then contact one of your officers and have them do it for you. But eventually you are going to have to fill out the form, and whoever answers the 211 call will provide you that form. Generally, they'll email it to you. They could fax it somewhere. Fractures. Fractures of the humerus or femur do not normally occur without major trauma. That is true. Fall from bed is generally not going to cause a fracture. Index of suspicion: if an infant or young child has a femur fracture. It takes a great deal of force to fracture a femur. One of our supervisor's grandsons fell off the swing set at school and fractured his femur. So it does happen, but it's not that common. If their fracture is complete, it took a great deal of force to make that happen. Remember, most kids are going to suffer a green stem fracture where the bone splinters. It doesn't actually completely sever. Shaken baby syndrome is generally, it's not as common as it once was. Very common for young single parents. Baby won't stop screaming. They do everything they can. Hours later, baby's still screaming. And out of sheer frustration and desperation, they have the baby and they shake it back and forward, back and forward. And the brain actually is playing ping pong ball against the skull, which causes contusions to the brain and eventually will cause loss of consciousness and eventually death. It could also, if it's done violently enough, it could sever their spine. When I do my CPR training, I tend to take one of the babies when we start it and hold it directly in front of me and shake it. People laugh and think I'm awful, but it's for a purpose. And this is something that does happen. It was a lot more common in the 70s, 80s, into the 90s. There was huge campaigns to educate people. And we've come a long way in our society. It tears blood vessels in the brain. Pressure from the blood increases cranial pressure, causing coma and eventually death. Neglect is the refusal or failure to provide life necessities, not providing water, clothing, shelter, hygiene, medicine, comfort, or personal safety. Neglect is often more common than actual physical abuse. Children will appear withdrawn or fearful. If the child does not want to discuss how the injury occurred, most children are more than happy to tell you what happened. A history of accidents is often a sign and something to be aware of. they tell you that their kid's just clumsy, falls downstairs and that kind of thing, you need to really be aware. And the abuser could be anybody the child knows, really. Anybody they spend a great deal of time one-on-one with. EMTs are mandated reporters. There's special forms. Supervisors are forbidden to interfere with the reporting. That doesn't mean they cannot assist you, but we're not allowed to convince you not to. And I'm a supervisor, and I have made it perfectly clear to all my volunteers that I will help them in any way they can, but I cannot listen to their concerns and say, I don't think you're right. You should not report that. That is not allowed. If you think you should report it, then you absolutely should report it. And for us, the best way to do it is 211. It's not our job to determine whether we're correct. It's only our job to state the concern that it is happening. Any age or gender could be victims of sexual abuse. Maintain an index of suspicion. Long-standing abuse is generally by relatives, close family members, where they're often alone one-on-one. Assessment should be limited to exactly what you need to do to control the life threats. And don't go looking down at the privates, the genitalia, without needing to, because you're concerned about hemorrhage. You cannot allow them to wash, urinate, or defecate until a physician completes their exam. This could be very difficult. It could be very uncomfortable, but it's very important. There's a good chance that they're holding evidence inside them, and you need to try to help protect it. This is one where a provider of the same gender is helpful, unless the patient was abused and assaulted by the same gender, then they might be more comfortable with the opposite sex. So again, nothing's absolute, and we need to make these decisions for each case as they present themselves. Again, professional, caring, compassionate composure are very important. Shield the patient. Get them in the safety of your ambulance as quickly as possible. Obtain as much information as you can without really prying too much. Remember, these kids are going to have to tell law enforcement or any other investigators everything that happened. So if we can limit how much we poke and prod on the details, they'll probably be more willing to share with the appropriate officials. SIDS, 3,500 infants annually. So these pointers, they're great for you if you're an expecting parent. But generally, when we get there to treat a patient in cardiac arrest who was found in its crib dead after being put down for the nighttime sleep or a nap, it's not our job to deal with this stuff other than to note. Somebody on your crew should take a look at the crib. Was it filled with a whole bunch of stuff? Find out if the family allowed the baby to sleep on its stomach. And understand that it's probably absolutely nobody's fault. Sometimes this stuff just happens. Mothers younger than 20 years old, mothers who smoke during pregnancy, low birth weights, these are all risk factors. It could happen any time of day or night. You need to assess the scene and take special note of what it looks like, any details, anything that looks out of place. Assessment and management of patient, and communication and support of the family. This is all part of your crew's job, not just you, but your crew as a team needs to manage this stuff. Expect pale or blue, breathing not responsive, no pulse. It could be an infection that was missed. It could be child abuse, airway obstruction, or meningitis. So it might not just be unknown causes. It might appear to be sudden for you on scene, but it might be found out later that there was absolutely a reason. Other causes, intentional or accidental poisoning. The kid eats something and nobody figured it out. Hypoglycemia, because nobody knew they were diabetic, but they were, or just became. Or sometimes it's a freak thing where their sugar drops. They didn't eat properly. Nobody knows, but it could not necessarily be the beginning of a chronic situation. It could be an acute hypoglycemia. And congenital defects. Sometimes things are missed by all the testing and awesome care our pregnant mamas and babies get. There could still be something underlying that was missed. Start with your airway breathing and then circulation. Remember, babies are airway driven. Provide necessary interventions. Depending on how much time has passed, postmortem changes. So rigor, dependent lividity, just like adults. If you see these signs, we should call med control. If you're concerned or just can't fathom looking at the baby and not trying anything, then by all means, do what you feel is right. But if they have rigor, there's nothing you could do, and you really need to accept it and call medical control for presumption. Of course, if they're still warm and pliable, we should do CPR immediately. Assess, pay attention to marks or bruises. Note any interventions that were performed before your arrival. Was a bystander CPR performed, rescue breathing, anything like that. Inspect the environment, noting condition of scene and where infant was found. You also need to try to get information as to where the bystanders found the patient. Concentrate on signs of illness, general condition of the house, signs of poor hygiene, how the family interacts with you and each other, and where the infant was discovered. And were they found dead on the floor next to the kitchen cabinet, where we know there's some pretty nasty stuff, or in the bathroom? Take special note of that stuff. Obviously, it's devastating to everybody. It's going to stay with you a long time, too. We need to try really hard not to show our emotions to the family. We need to let them grieve and try to be the strong ones for them and deal with their own stuff after. Provide the family empathy and understanding. That absolutely is important. We cannot assume it's their fault. It might be found to be their fault later. There's a good chance it won't be, but just the same, that's not our place. We need to care for everybody. We need to stay, not equal. Neutral, that's the word. We need to remain neutral. And the bottom dot, introduce yourself to the parents or caregivers, ask about the child's date of birth, get your sample history, and care as best you can. Again, don't speculate on the cause of death. That is not our place. Families should be asked whether they want to hold, say goodbye, and ultimately, if you're not providing life-saving interventions or attempting, then the parents, family have every right to do as they wish. Police should be called. We should be remaining on scene until the police arrived. Refer to the child by name. I use died or dead instead of passed away or gone. I'm not sure. That's a decision you really need to make for yourself. Gone's generally not a good one. There's no easy way around this topic. Acknowledge their failings, but never say, unless you've lost a child, never say you know how they feel. Because unless you've experienced the same thing, you don't. If you have experienced it, then by all means, share your experiences with them. Offer to get in touch with somebody, to be with them. Keep instructions short and simple. not remove equipment that was used in attempted resuscitation. That goes for adults and children alike. If somebody put a tube down their throat, a medic, we do not rip it out. If we put an oral airway in, we don't take it out. Understand that some family members may require interventions. You might be clearing without the dead baby, but you might end up taking the mom or dad or grandma who's having a panic attack. A lot of times they will feel responsible, and we need to be aware of that. EMS systems arrange for home visits after a child's death for closure. We don't do that. I don't know any system in Connecticut that does that at the EMS level. For sure, be aware that this could be a very stressful situation for you. Most of these calls don't ever leave you, but it's up to us to get the help we need if we cannot manage it on our own, and that's okay. Some people are able to, some people need help. And if you need help, you need to ask for help. In the volunteer organizations, you should have a safety officer or just an officer that you confide in that could provide you with how to get this help. There should be employee assistance programs available, whether you are a commercial provider or a volunteer. Those services are out there for us. So if we properly stimulate and ventilate the patient, there's a good chance that a child can come back to us pretty quickly. After ALTE, child may appear absolutely fine, but we need to carefully assess and provide rapid transport. There's a good chance that if they went unresponsive, pulseless and apneic, and then returned, there's a good chance they're going to go back to pulseless and apneic. We do not want to let these parents refuse transport. Strict attention to airway management. Remember, airways, all that really matters in these kids. Assess their medical history, the environment you find them in. Allow caregivers to ride in the back of the ambulance with you unless they're absolutely out of control, and let the physician deal with the cause. All right. I think at 2 hours and 27 minutes, I have taken enough of your time for this topic. Ultimately, a lot of it all relates to general patient care. We're going to change a few things up because they're itty-bitty kitties, but for the most part, what we're going to do is pretty much exactly the same. So thank you for watching. Please get in touch with any questions or comments, or just to say hi. I miss you all. Goodbye.